Glad you're here, Dr. Wang. Welcome. So let's officially get started. So for everyone out there that has joined, I am Kristen Whedon, and I serve as president of the United Porphyrias Association. And I'm so happy to welcome Dr. Bruce Wang, who is hepatologist at University of California, San Francisco. But for us, most importantly, Dr. Wang is a Porphyria expert, and he has joined us this morning to respond live to your questions about porphyria. We find that so often you have questions that either you forget when you go to a doctor or you don't have access to a doctor, and this is such a valuable opportunity to ask to Dr. Bruce Wang live. So Dr. Wang, we'll get started with questions in just a moment. Do you want to take a moment and introduce yourself
Sure.
a little bit and a little bit about doing this?
Sure. Happy Saturday, everyone. So I'm a hepatologist and a physician scientist here at UCSF. I've been running the UCSF Porphyria Center for the last close to 10 years now, and have been part of the Porphyrias Consortium here in the US. So really happy to be here, and the purpose of this session is for all of you who are online. I'm here to answer any questions that you guys may have. Also, having done this a couple times before, I think we usually run out of time before we can go over all of the questions, and I think usually Kristen and the team at UPA will take down the questions that have not been answered, and then we'll figure out some way for me to get some of those answers to you guys afterwards.
Great. Thank you, Dr. Wang. And to set some parameters, please type your questions in the chat, and I am going to read the question to Dr. Wang, and he will give his response. And when we're done, we'll go on to the next question. So Dr. Wang, to start, the first question is regarding PCT, or Porphyria cutanea tarda. And the question is, I recently developed PCT and would like to know if there is a safe consumption of alcoholic beverages, beer, in this case, or if I need to stop drinking permanently.
Yeah, really good question. So in Porphyria cutanea tarda, most people who have PCT is actually the only porphyria that can be acquired, meaning that you do not have to have inherited a mutated gene that encodes for this particular enzyme, urodecarboxylase. UroD. And one of the main reasons why PCT develops is because of alcohol and its effects on the liver, in particular an increase in iron content in the liver. So in this particular case, in general, I would say it is important to cut down on alcohol, but my general recommendation is to abstain from alcohol completely. Now, I think it does matter in individual cases what the underlying cause is of your particular, why you have PCT. Just as an example, sometimes people have PCT because they have another condition, for example, hereditary iron overload or hemochromatosis, which causes their liver to accumulate iron. And then in that case, any additional stress on the liver, for example, some alcohol can trigger it and induce PCT. In those cases, if you got rid of the extra iron by phlebotomy, for example, it may become safe for you to have an occasional drink. By occasional, I probably would say that one drink per day is probably too much, but an occasional beer once or twice, a week or every other week, that probably would be fine. But again, it really depends on what the underlying cause is. So my general recommendation is to abstain from alcohol completely, but depending on what the underlying cause is and how treatable and how treatable that underlying cause is, you may be able to have some occasional alcohol.
Great. Thank you, Dr. Wang. The next question is about EPP, or erythropoietic protoporphyria, and the question is specific to vitamin D. The question, and vitamin D deficiency. It's quite specific, so we'll see how you want to answer it. But the question is, my vitamin D is at a 6, and I've tried every supplement brand off the shelf and have done countless rounds of the 50,000 units prescribed by my hematologist. Still can't elevate my vitamin D level. My tolerance to direct sunlight is at the very most 10 minutes. I have also tried the artificial light lamps, looking for help with this.
Yeah. Um, uh, Really good question. This sounds like a tough case in particular related to vitamin D. So just in general, vitamin D is in general in our body is produced after exposure to sunlight. And so for EPP patients and also for other cutaneous porphyria patients, for example, those with CEP who really have to avoid sunlight, vitamin D deficiency is a common occurrence. This particular instance, boy, I'm not sure if I actually at this point have a specific recommendation. I think that I have to dig into this a little bit more about other forms of supplement therapy. I think you've gone through the typical routes that I would think of, including talking to an endocrinologist and trying some additional methods of supplementing to increase your vitamin D levels. So I think I'm going to have to do a little more research and get back to you on this one.
Great. So we will, with that, once you have done some more research, we can post that likely as a What's Up doc question and answer.
Yep.
So we will do that. Okay, the next question is regarding acute intermittent porphyria. And the question is there any way to replenish my heme other than heme injections? Also, what can I do to replenish my cytochromes?
Yeah. So I want to actually make a general comment about levels of heme in the body, actually for patients with porphyria in general, and then specifically in AIP. So patients with all porphyrias have in general, again, except for some cases of PCT that I just mentioned, have an inherited defect in one of the heme production enzymes. By and large, though, these enzymatic defects do not lead to a deficiency of heme in the body. Okay. In AIP in particular, it's not that there is a deficiency of heme in the liver, it's that would trigger an attack, for example. And in fact, your liver is making the normal amounts of heme that is needed to maintain its normal function, including for all of the cytochrome enzymes in the liver that require heme as a main cofactor. Okay, so there's no underlying defect in AIP patients of a heme deficiency. What happens is that if something were to trigger the liver to have to make more heme than is needed in the normal instance, that's a case where then having this genetic defect in AIP, having a mutation in the HMBS gene, means that the liver can't quite keep up with the increase in demand for heme. And then that's the context in which case there's a bottleneck that forms and the liver accumulates high levels of ALA and PBG, and then you have an acute attack. Even in the setting of an acute attack, there's been no data that we could find in patients, in animal models, or in cell culture where we can actually show that the liver has a heme deficiency or that there is not enough cytochromes. Okay, so my answer to the question is that there is no need at baseline when you're not having symptoms of an acute attack to try to replenish heme, because actually there is enough heme in the liver, and also by extension enough cytochrome P450 enzymes in the liver. So that's number one. And number two, it actually turns out it is really hard to replenish heme directly. It's been tried. Taking heme orally does not work because it rapidly gets degraded as soon as it is ingested and absorbed across the intestinal membrane. So really, that's unfortunately why currently the only way to actually replenish heme in the liver, or I shouldn't say replenish, is to give enough heme to the liver to shut down the heme production process so that we are no longer producing excess ALA and PBG. And the only way to effectively do that is to give heme intravenously.
The next question is also regarding AIP, or acute intermittent porphyria. It says, during an attack, I have lots of pain, but when that subsides, I always still have mild pain and muscle weakness. Why? Thank you.
Yeah. So, so in all of the acute porphyrias, AIP, those patients with varicate porphyria or hereditary coproporphyria who also experience acute attacks, we think that the acute attacks, the symptoms of the acute attacks, especially including abdominal pain, but also all the other neurologic symptoms, are caused by high levels of these two chemicals, ALA and PBG, and probably ALA more so than PBG. And high levels of these heme precursors damages nerves in the body. Now, nerve damage, depending on the severity, and generally in terms of the severity that you experience in an acute attack, it's a reversible damage, which is why the vast majority of patients will recover from their acute attack. But nerves also recover slowly. So unlike, let's say, I don't know, a muscle strain or something, you know, a mild strain, you might recover after just a couple of days. Nerves take oftentimes longer to recover, and the recovery time also depends on the degree of damage. So it's very typical for patients to have symptoms that linger for weeks and sometimes months after an attack. And the longer the attack, the more severe the attack, the longer the symptoms may linger. This is also why I think it's really important that, number one, you have access to treatment when you have an acute attack. We've already talked about heme and intravenous heme. That is the way to, you know, that is currently the only FDA approved way to treat and to stop an acute attack. So make sure that you have access to it. And then as soon as you recognize that you're going into an acute attack, my recommendation is for you to get heme as quickly as possible. The main reason is so that you can shorten the recovery period. You know, really prolonged severe attacks can lead to permanent neurologic damage, and that's what we really want to avoid. But getting treated quickly within, you know, 24 hours of initiation of a severe attack can really help shorten how long you have these residual symptoms. Of course, that requires that you have access to panhematin treatment.
Okay. Thank you. We are going to flip over to a question regarding CEP, or congenital erythropoietic porphyria. And the question is, my 5-year-old daughter has CEP, but the doctors still don't know the severity. We have done the genetic test, but how can we tell the severity of her condition?
Yeah. So with CEP, it's caused by mutations in the EuroS gene, and patients with CEP have mutations in both copies of the EuroS gene and accumulate really high levels of porphyrins, in particular uroporphyrin. And CEP patients can present with a range of symptoms. We generally think of, you know, we used to think of CEP as sort of almost uniformly severe, that it always presents in childhood. But we have now have seen some patients with, depending on the mutation that they have, really only symptomatic manifestation as an adult. Okay, so there is a range. But the way to determine severity of CEP is actually to check for urine porphyrin levels. How high are the, you can do this on a random urine test and look for fractionated urine porphyrins. You're looking at the total porphyrin level, and you're also looking at the uroporphyrin level, okay? So, and going forward, I'd recommend that be checked on a regular basis. So even if your child is not having symptoms and really otherwise feel like she's doing totally fine, I would still recommend that you get and check urine porphyrins once every, I'd say, you know, the minimum once a year, probably more like once every 6 months, just to track it, because it will help you figure out, you know, how safe is it for your child to be exposed to sunlight, for example. Now, in the more severe cases of CEP, the high levels of uroporphyrins actually cause damage to the red blood cells, and they get what's called hemolysis, where the red blood cells break apart and lyse. Those patients have anemia that can present with weakness, tiredness, fatigue. So those are symptoms that I think are generally pretty, especially in a child, fairly easy to identify because the anemia tends to be pretty severe. At that level, certainly the child will have really red urine. It's another thing to watch out for. So, but if your child does not have hemolytic anemia as a result of CEP, then the severity, the other way you'll know is whether or not your child has skin symptoms. So with any sunlight exposure, they may start developing blisters, similar to the blisters that are seen in patients with Porphyria cutanea tarda, PCT, for example, or even patients with variegate porphyria and HCP, because some of the porphyrins that accumulate are similar across those different cutaneous porphyrias, and you'll get this this blister, and you'll get mostly in hands and face. They'll have really fragile skin. So that's something to watch out for. With CEP patients, it's really important to watch out for these kinds of skin symptoms and really try to prevent them, because the levels of uroporphyrins are so high that once these skin blisters form, the top layer of the skin will peel off, and actually there's very delayed wound healing, and those wounds are at very high risk for infection. And it's the infection of the open skin wound that ends up causing most of the skin manifestations and defects in CEP. So you want to be really careful of that. So you can also assess with severity based on what kind of symptoms your child has. The most severe being having anemia, where they're transfusion dependent. Maybe every couple of months, they would need a blood transfusion for more packed red blood cells to replenish the lost red blood cells. On the mild end, you may have we have patients who don't really have any skin symptoms until perhaps even sometimes later on in adulthood. So within that range, you can have based on the kind of symptoms that your child has, you can get an estimate. But I think the best way is to check the child's urine for porphyrin levels.
Great, thank you. We are going to continue with a question about exposure, but it's about variegate porphyria. And the question is, I have variegate porphyria and I get blisters without even being outside. Is this common?
Yeah, so having blisters without being outside is uncommon, especially in variegate porphyria. The way that I would assess this is actually very similar to the comment I gave about CEP, which is I really would want to know what your porphyrin levels are like. So I mentioned earlier with acute attacks, which variegate porphyria patients can also have. In those cases, when we're thinking about the neurologic damage that can happen associated with abdominal pain and then other kinds of neurologic symptoms, we're thinking about two specific chemicals, ALA and PBG. Mm-hmm. They are in fact not porphyrins because of their chemical structure, they're heme precursors, and a usual porphyrin test doesn't include those, okay? But the skin findings that occur in variegate porphyria, as well as CEP and PCT, those are caused by different kinds of heme precursors, and those are porphyrins. So in your particular case, I'd want to check your urine. Again, can be done on a random urine sample for fractionated urine porphyrins, and I want to know what the levels are like. Depending on how high they are, I can give you then we can give a better idea of how much are you at risk for actually sunlight-induced skin blisters in variegate porphyria. The reason I mention this is that there are other causes of blistering skin lesions that are not sunlight-induced, and so it's possible that the reason you have skin blisters may not be related to your variegate porphyria, and the way to confirm that would be to check the urine porphyrin. Plus, knowing your urine porphyrin levels will give you a better idea of how likely you are to develop skin blisters if you're exposed to sunlight. So now patients with CEP who have generally much higher levels of porphyrins in their body than patients with varigate porphyria can sometimes get skin lesions just by exposure to indoor lighting, because there's certain wavelengths, depending on kind of indoor lighting you have, there are certain wavelengths that can activate to a much lower extent than sunlight porphyrin levels. But I haven't really seen that in varigate porphyria patients, again, because the levels of porphyrins aren't high enough generally in varigate porphyria patients. So in this particular case, I need to see what the urine porphyrin levels are like in order to get a better idea. But that's the place that I would start with.
Great. And this is a question I'm seeing just kind of quickly related to varigate porphyria, that why do some patients get blisters and other patients don't?
Yeah. Really good question. So in general, in the acute porphyrias, so acute intermittent porphyria, varigate porphyria, hereditary coproporphyria, all three of them are genetic diseases that have that don't always manifest. Okay, and so the kind of the technical term for that is that these are genetic diseases with low penetrance. Okay, this applies certainly to the acute symptoms and the acute attacks, but applies also to the skin symptoms. So it probably means that, number one, it depends on the kind of mutation that a patient has. Across different families, the mutations are different, and the severity of those mutations, meaning how much does that mutation sort of decrease the function of the enzyme, differs. That's one. Two, there are probably other factors outside of mutations in that particular gene that affects heme production and the manifestation of the disease. A lot of these cofactors we don't know. Some of them we do. For example, sex hormone levels. We know that plays a big role. Other things like medication use and how much that might trigger the liver to need to make heme. That also factors into it as well. So that applies both to acute attacks as well as skin symptoms. So this is why actually, the vast majority of patients with varigate porphyria, actually who have the same mutations, don't develop any symptoms. And we don't yet fully understand, why it is that some patients do.
Okay. Which is a good reason to participate in research, right?
Correct.
Okay. So we're going to flip over to an EPP question, erythropoietic protoporphyria. Hi, Dr. Wang. My 10-year-old daughter has EPP. She has had bouts of pain in her hands and nose over the winter this year. Is the first time it's happened in the winter. Do you think it's hormone or age related, or should we be looking at our lights and TV, etc., even though she has never had previous issues with this?
Yeah, that actually is a really good question. So with EPP, patients with EPP generally have, patients with EPP have abnormally high accumulations of a porphyrin called protoporphyrin. Protoporphyrin production and the accumulation occurs in red blood cells in the bone marrow. Okay, and we don't usually see changes in red blood cell and hemoglobin production in the bone marrow with puberty, for example. Okay, where we can see changes is, for example, if your child for whatever reason is developing some even mild levels of anemia, so which could be due to other reasons. Okay, so I guess first my answer is, we have not seen a clear age-related changes in EPP symptoms and severity. When we do see a change in the symptoms, generally it means that something has changed in the bone marrow where the red blood cells probably are having to make more heme than they've had to. okay, if you think that the exposure is absolutely has not changed, right? So I should back up for a second and say, most often if you're having, a change in symptoms, you should think about exposure. Is it, has the weather pattern this winter been different than other ones? Is there any less, skin protection from even indirect, reflected light being outside than usual? So I would start with that. But if you're pretty sure that you haven't really changed the exposure at all, before going into, hey, what about indoor light exposure? The other thing that I would think about then is, hey, has something changed in the need and production for heme in red blood cells? So this may be a good time to go check with your pediatrician and say, hey, can we just check a blood count to see if there's any signs of anemia? Because that may be why, if nothing else has changed in terms of exposure, that she's having more symptoms this winter.
Okay.
Yeah, but then also, sorry, just to finish with that, for EPP, I think in general, we don't think of indoor lighting, at least, in sort of the everyday exposure to indoor lighting, as causing significant amounts of symptoms. There are exceptions to that. So, for example, during medical procedures where you have a relatively intense and potentially prolonged exposure to light in a particular area of the body, that has been known to induce pain. For example, during dental procedures or during operations. So that certainly has happened. But in general, I would say indoor lighting these days don't usually cause significant symptoms for EPP patients. So that's why I don't think that that's the likely explanation in this case.
Thank you. So AIP question. Sometimes my kidney blood results are slightly high and sometimes they're normal. Can AIP cause this?
So yes, another really good question. So patients with AIP are at increased risk over the long term with developing chronic kidney disease. Okay, there's a couple of different potential causes for that. Number one, during acute attacks, the autonomic nerves, those are the nerves that control blood pressure, heart rate, they are damaged by high levels of ALA. Okay, and so you get bouts essentially of high blood pressure during acute attacks. And if you have, a number of acute attacks or current ones, the increase in blood pressure and the sympathetic nerve stimulation puts you at risk for developing some kidney disease. Okay, that's high blood pressure is probably the most common cause of kidney disease in general. So that's one. Number two, there are a small group of patients who have AIP who also may carry a mutation in another gene called PEPT2. This particular gene encodes for a transport enzyme. Basically, it encodes for the enzyme that shuttles ALA, again, the chemical that causes all of the damage in terms of acute attacks in AIP. PEPT2 shuttles ALA across the kidney so that you can pee it out. Okay, patients with a certain kind of mutation in PEPT2 accumulate even higher levels of ALA in their kidneys than other AIP patients who are also having acute attacks. And the patients with PEPT2 have been known to have worsening kidney function. Okay, and so I think it would be worthwhile for you to connect. You can connect with me or someone else in the Porphyrias consortium, and we could do genetic testing for PEPT2. Okay, in general, though, patients with acute hepatic porphyrias and who have acute attacks, they are at risk for kidney damage. It generally is not severe enough to cause kidney failure. So there are very, very few acute porphyria patients who end up on hemodialysis. But you may also be at risk, have other risk factors for kidney disease as well. So it is important to monitor your kidney function. We generally recommend that you do that at least once a year, which sounds like you are doing.
Thank you. Another variegate porphyria question is that, is there anything at all we can do regarding the blisters for a VP patient? My face is scarring horribly from the blisters. Catherine says that Kristen has seen a photo or two, and I have. Is there something we can take before maybe like a Valtrex or something to lessen the lesions? Is there anything she can do for the blistering on her face, especially?
Yeah, yeah. Actually, with varigate porphyria, it's the same thing with HCP. Although varigate porphyria patients have blisters much more frequently than HCP patients. Um, uh, there isn't, unfortunately, a whole lot that's available to help prevent the blisters. So, unlike in PCT patients, for example, where phlebotomy or hydroxychloroquine works really well, those don't work for varigate porphyria patients. And if you're not having acute attacks just for the skin symptoms, you know, um, uh, there's a little bit of data out there about heme, but heme wouldn't be indicated. Your insurance company is going to cover heme treatment, let's say with panhematin in this country, just for the skin blisters. So there isn't a whole lot that could be done to help prevent it, other than just really careful sunlight avoidance, unfortunately. And then and then careful skincare with once you have the blisters. So make sure that you're consulting with the dermatologist about the wound care aspect of it once you've developed blisters.
Okay. Thank you. We have a question about EPP and the current clinical trials, specifically on MT-7117 by Mitsubishi Tanabe. And the question is regarding EPP in the current trials, when will it be accessible to pharmacies around the nation and approved by the FDA? So it's a drug
Yep.
development question.
Yep. Got it. I'll answer this first a little bit more generally about drug development overall. And I think that's relevant because there's we've had two drugs that have been approved by the FDA over the last 10 years or so. And there's at least two more that are currently in sort of the pipeline. So the process for getting a drug developed, and usually by the time that porphyria patients become aware of these drugs is when they've already gone into clinical studies. Perhaps as early as a phase 1 clinical trial. Those types of clinical trials are primarily for safety. So that's when you first give the drug to generally either healthy volunteers or patients with disease, but where you're not trying to really assess for efficacy, you're really just trying to assess for safety. And those are generally fairly small trials of with the porphyrias, you're probably talking about maybe dozens of patients. And once safety has been pretty well established, then you go to a phase 2 clinical trial. So with Mitsubishi Tanabe, that's also, for example, completed a phase 2 clinical trial. There's another company, Disc Medicine, which has an agent bitopertin that currently is just about to wrap up a phase 2 clinical trial. So now in a phase 2 clinical trial, you're still looking at safety, but with a larger number of patients, but you're now also looking at efficacy. How effective is this drug for the main symptom that, the main indication that you want to treat it for? So for EPP, for example, it oftentimes is, does it improve or increase the amount of time that a patient can spend in sunlight? Now, phase 2 studies, oftentimes at this stage, there may be multiple doses of a drug, and it's unclear which dose is the appropriate one. And so phase 2 studies oftentimes have multiple doses that are being tested at the same time. And then if a phase 2 study shows, number one, safety, so we're always making sure that, safety, that's the number one reason that drugs fail, even before they get into these kinds of phases of clinical trials, is because of safety issues. If it's safe, and then if it shows effectiveness, which the Mitsubishi Tanabe drug dorsamelagon did show in phase 2, then you move to a phase 3 study, which includes even more patients generally than in phase 2. Although for Porphyria studies, those are difficult just because there aren't that many patients overall. So oftentimes the numbers aren't hugely different. You're not talking about orders of magnitude different in terms of numbers of phase 2 and phase 3, but generally phase 3 then only has a single dose, and it's primarily just looking at efficacy, although they're always still following safety. So, and then after a phase 3 study is completed, generally, then depending on how effective the drug is, that they reach their endpoint, then it's a evaluation by the FDA for approval. So that process can take quite a long time. So of the 2 drugs of the last 10 years that have been approved, the more recent approval, the more recently developed drug, gavosiran, which is used for the acute intermittent porphyrias, that had what I would consider a relatively quick approval process. It had a successful phase 2 clinical trial, a successful phase 3 clinical trial, and I want to say definitely within 2 years of completion of the phase 3 clinical trial, it was FDA approved. All right, that's on the fast end. You have on the other end, SCENESSE, for example, where the phase 3 study ended back in, was that 2014? 2013, 14, right? So, you know, and then that drug was a little, its approval process was a little more complicated. It was approved in Europe first, but it took a total of 5, almost 6 years from when the phase 3 study ended before the US FDA approved it. So, you know, it's really difficult for us to say definitively, number one, whether a drug is going to get approved at all, especially when the phase 3 study hasn't been fully completed. And so for the Mitsubishi study, Mitsubishi drug, they're restarting a phase 3 study very soon. I think it started already.
There are 3 study sites that are open in the US with another several happening over the next few months. Right. And then it's also will be a global study.
Correct. Yeah. So I think you're looking at the end of 2024 for when the randomized double-blind period for this phase 3 study to end, and then there's an open label extension period. So and then takes a little bit more time to then analyze the results, and then depending on that, then you go through the FDA process. So it'll still be a little while.
Yeah. Okay. With AIP, is it a symptom to have pain and twitching spasms on my right side for an attack coming on? Is it a symptom to have pain and spasms, twitching and spasms on my right side? Does that indicate that an attack is coming on?
So this is what I'll say with acute attacks. There is a whole wide range of symptoms that patients can experience for acute attacks because all nerves in the body can be affected. Okay, but for each individual patient, the symptoms tend to be consistent from one attack to the other. Okay. Now, the other thing is that in general, we think of the symptoms that patients get in the acute porphyrias as typically non-specific and not really focal because you're talking about nerves that being damaged, not, for example, when you have appendicitis, patients oftentimes can point to a particular spot with their finger and say it's that tiny little area that really hurts the most, right? With acute porphyria, in general, most patients say, oh, it's a wide area in the abdomen that has symptoms. So generally, we think of the symptoms as being a little bit wider in terms of area and probably affects arms and both sides and legs and both sides as well. Having said all that, I would base this on your own experience and the fact that with acute attacks within a single patient, the symptoms tends to be consistent throughout. Okay, so if for you, every time that you've experienced an acute attack, right, that's eventually progressed to a more full-blown set of symptoms, that's always preceded by this very specific one-sided kind of symptoms, then I would say, hey, that's a pretty good warning sign for you. And if that's the case, then that's the time I would all right, let's try taking in some simple carbohydrates at home before you start developing abdominal pain and nausea and vomiting to see if that can help, because that's easy to do and it's very safe. right? But then also that may be the time for you to start preparing for, hey, this might develop and progress to an acute attack, maybe in the next 24 hours, maybe in 48 or 72 hours. And so that then, I don't know, maybe if you're planning on go on a trip right away, you might say, ooh, let me hold off for a little bit because this might lead to an attack coming on, right? So if this is a consistent symptom that tends to precede the other symptoms of an acute attack for you, then I would treat it as a warning sign.
Okay, great. PCT question. Do you consider stress a trigger for PCT, or can it make a PCT worse?
Yeah, it can, both directly in that, we've seen for both PCT and some of the other, for example, the acute porphyrias, that stress can increase heme production in the liver, okay? And then also stress and how we then deal with stress can also trigger, cause additional stresses on the liver. So for example, some people, when they're more stressed, they might take in a little more alcohol, and that certainly can then trigger, or some people who use cigarettes, for example, may increase cigarette smoking, and that's also been known to further inhibit urodefunction in the liver. So, so I would say yes, that broadly stress, both by itself and some of then the adaptive responses that we may, employ to deal with the stress can all exacerbate and potentially trigger a PCT attack.
Okay. So Tina asked a question, can you please send info, or a comment, can you please send info widely to ERs about porphyria? The ER completely missed it when I was having an attack. And I know this is something of interest to you, and I think you might want to comment on it, on that phenomenon, that how this happens within the acute porphyrias especially.
Yeah, yeah. So this is, thank you for the question. And unfortunately, this is a very common experience for our acute porphyria patients. This is something that for me, as well as, the broader, I would say, porphyria clinical and clinical research community, we have been trying to increase awareness with the emergency room physicians. The pushback that we have generally gotten from the ED physicians is that this is a rare disease for a for in the ED setting, a very common indication, abdominal pain. And the way to diagnose acute porphyrias is using, still unfortunately this, right now, using available tests, urine, ALA, and PBG tests that are not rapid tests where the results don't come back on the same, within an hour or on the same day. Generally takes 3 to 5 business days for those results to come back. And that's just not how, sort of emergency rooms like to make their decisions. They don't want to make a decision on the spot using a test that they can't find out the results for until 5 days later. And so they've actually been really resistant to do more urine, ALA, and PBG testing in patients that don't have a confirmed diagnosis. So we have been trying to do studies. I recently tried to do one here at UCSF, trying to show that if we do more widespread urine, ALA, and PBG testing, that you'll be able to pick up acute porphyrias, and that is not as rare as the ED physicians think. The ED physicians think that it's 1 in 10,000 patients that comes in with acute porphyria, with acute abdominal pain. It is certainly not that much. I think that it may be in 1 in 500, in which case the problem is that we don't have any data thus far to show that, right? And then in the absence of that data, there's the emergency room physicians always then come back and say, well, show us the data that this condition is a relatively common cause of acute abdominal pain presentation to the emergency room, and then we will test more widely. So that's kind of the state of where things are. For all of my patients who have confirmed acute porphyria, I read a letter on their behalf. They take it with them. I give them, my patients have my contact information. I always tell them, have the ED physician give me a call, or you can contact, I have my patients reach out to me and I'll give the ED a call and let them know about the diagnosis, right? But that only works if you already have confirmed acute porphyria and you have, someone that taking care of you. There's certainly an unmet need in those patients who have not yet been diagnosed. And I think we can pick up the diagnosis much quicker if we can convince our ED colleagues to check for urine ALA and PBG more often. The other way that this could improve is if there were a widely available and easy to use rapid ALA or PBG test. There is one right now, but it's not the easiest to use, so it hasn't been widely adopted by EDs.
Yeah. Okay, terrific response. Thank you. Can AIP cause fibromyalgia? I think I pronounced that wrong. Fibromyalgia.
Yeah, I would say that AIP would not cause fibromyalgia, but patients with AIP who've had acute attacks, and especially who've had, say, recurrent attacks that then have residual, neurologic damage, can have symptoms that might be very similar to those symptoms that patients with fibromyalgia have. So I think that's how I would think about it.
Okay, thank you. So Dr. Wang, we're at the top of the hour and I do realize we did start late. Do you have a few more minutes?
I do. Yeah, no, that's fine. I'm happy to stay
okay.
longer.
Okay, thank you. So maybe about 10 more minutes. Would that be okay?
Sure.
Terrific.
Sure.
Thank you. And just so you know, in the chat, there are so many thank yous and so much appreciation going on for you doing this. So you probably haven't been able to see that, but I want you to know that there's much appreciation for these, your responses.
Thank you.
Yeah. Okay. I have an EPP question, and it is regarding menopause. Do EPP patients have more sensitivity during menopause?
I would say in general, not that we know of. And again, I talked about this a little bit earlier when we talked about EPP and in the start of, going through puberty and start of menses. Again, with EPP, the source of protoporphyrin production is in the bone marrow. With menopause, and generally, we think about changes in porphyria manifestation with menopause more with the acute porphyria patients, because in those patients, it's the liver that is the source of high levels of ALA and PBG, and the liver is an organ that metabolizes and breaks down hormones. And during menopause, there's significant changes that occur in the liver. And generally after menopause, there is sort of less, hormone fluctuations. And so there's less of a changing demand for heme in the liver. And so patients with acute porphyrias generally have decreased risks of acute attacks after menopause. For EPP, again, the issue is in the bone marrow. It's the red blood cells that have to make hemoglobin that are the production of protoporphyrins. And while I'm sure that there's some changes during menopause with the bone marrow, it's not as significant, sort of dramatic changes in heme production levels. So generally, we don't think of menopause, before and after as having a significant change in symptom severity for EPP patients. But the way to actually check that is still actually, I think patients with EPP should have fairly regularly, maybe once a year or so, just have a CBC, a blood count done to check their hemoglobin levels to make sure that they're not changing very much. Because when those levels do change, you probably will start seeing some changes in your symptoms.
Okay. I think this is an area, Dr. Wang, for a future write-up, as we have some in the chat from, you just responded to that about EPP, but we have follow-up questions about HCP and perimenopause and VP and perimenopause. So maybe we can, you did a great response now, but maybe we can expand on that soon.
Sure.
So the next question, which I like, can we talk about memory loss and confusion? So the answer is yes, we can talk about memory
Yes,
loss.
we can.
But
Yeah,
particular confusion for acute porphyria.
yeah,
Can you discuss a little bit about why that happens uh, and elaborate on that?
sure. So in the acute porphyrias, during acute attacks, the problem all really for the acute porphyrias and all of the neurologic symptoms, which spans from abdominal pain, which is the most common, weakness, numbness, tingling, that generally symmetric, but could be one-sided, as we'd heard earlier, to changes in blood pressure and heart rates, to then changes in mental status. The central nervous system gets affected as well. All of those issues in the acute porphyrias are caused, we think, by high levels of ALA and PBG, right? Probably mostly ALA. ALA can get into the brain and it can damage nerves in the brain. It can cause mental status changes where people have mental fog, have confusion. That is certainly present, can be present during acute attacks. Again, it's not present in everybody, right? Sort of the exact symptom manifestation changes from one person to the other, although within the same patient, the manifestations tend to be consistent. So if you've had a certain set of symptoms during your first attack, chances are you're going to have probably the same set of symptoms with subsequent attacks. And with each attack, they're all going to feel, in general, fairly similar. The severity might change. You may have some attacks that are really severe with the pain, and the other symptoms are much more intense and perhaps last longer, okay? But the kinds of symptoms that you'll feel generally are pretty consistent from one attack to the other. Really what it means is that, you have certain nerves in your body that are most sensitive to high levels of ALA, and those are going to be the same nerves that get, damaged and sensitized every time that you have high levels of ALA and PBG. Okay, so central nervous system issues are common. They do occur, and as we talked about earlier, it's a episode of neurologic damage, and so the recovery from that can take a while, and so the symptoms can persist for weeks, sometimes months. Generally, there will be some slow, steady improvement, but they can certainly linger, and really important that we try to treat the attacks and stop them as quickly as possible.
Okay, thank you. What does ALA and PBG stand for?
Yeah. Sorry, I should have clarified that at the beginning. So ALA, it is the very first intermediate. So heme, actually, this is the first time I've gotten this far and I haven't talked about the heme pathway. So heme, made in every single cell in our body, right? Really important protein that gets used in all kinds of things. Hemoglobin, red blood cells, that allows us to, extract oxygen and carry it to every single cell in the body. That requires heme. That actually requires a lot of heme. Cytochrome enzymes in the liver, the ones that allow our liver to break down all the chemicals that we eat, every medication that we take. All of that needs to get broken down, and cytochrome enzymes require heme as a major component of it. So heme is made in every single cell in the body. You can think of it as being made in an assembly line, and there are 8 steps in this assembly line. And you start off with some starting material, and after the first step in the assembly line, you end up with a compound called ALA. And the full name for it is delta amino levulinic acid. Really long name, which is why you say ALA. Once ALA is made, at the second production step, some other things get added to it, and then you produce the second compound called PBG, or porphobilinogen. Okay, these 2 compounds are heme precursors. At the third step, production step, then PBG gets made actually into the first porphyrin, which is a ring compound that gets light sensitive, and then those can lead to eventually skin symptoms. The very last step of this process takes a compound called protoporphyrin. So we've been talking about that in EP patients. It takes protoporphyrin, inserts a molecule of iron into it to make heme. Okay, so ALA is delta aminolevulinic acid. PBG is protoporphyrin.
Okay.
I'm sorry, PBG is porphobilinogen.
Yes. Okay, I got to get to this question for Carrie. Carrie, so you know I've been trying to get here. The question is about treatment for EPP in Scotland. And she has an appointment at, I believe it's Dundee, and the questions are really what should she be asking, and is there treatment in Scotland? So I understand you may not know this, answer, Dr. Wang. You may want to comment, but Carrie, just know that we'll follow up with you as well.
Yeah. So EPP, there's currently one approved drug both in Europe and in and the United States for EPP. It's a medication called Scenesse. The way that Scenesse works is it's an injection that goes underneath the skin. It's given now it's given once every 2 months, and the way that it works is it stimulates the pigment producing cells in your skin, the melanocytes, to make more pigment. So essentially you get more tanned. And the melanin, that's what these melanocytes, that's the pigment producing cells make. The melanin essentially gives you a little bit of barrier protection against sunlight, so that not as much sunlight penetrates through the top layer epidermis of the skin to activate protoporphyrins. And patients are able to tolerate more time in the sunlight on Scenesse in general than without. So that's the current drug that is approved. Accessibility to Scenesse has been difficult. It's been difficult in this country. In general, it's not widely available. You know, just as an example, I cannot prescribe and give Scenesse at my center. And I've so I think the company has has a certain they've decided on a path, a strategy of distributing the drugs, and primarily it's only available through certain dermatology clinics that the company has chosen. I personally don't. I wish that the drug were more available, and I certainly think that as a Porphyria center that I should be able to prescribe the drug. So that's the situation here in the United States. I think the situation in Europe is also similar in that it is not widely available. I think for a number of years, access to Scenesse were restricted to a few academic Porphyria centers, primarily that had a dermatologist. So Switzerland, for example, I know has been a pretty consistent site for availability for Scenesse. And apologize, I do not know what the situation is like in Scotland. I know that Cardiff in Wales has had a very long-standing Porphyria center, and they've had dermatologists there, but I don't actually know if they are one of the Scenesse centers in Europe.
And we can follow up on that, Carrie. Okay, I'm going to do one more question, and then I'll tell you what we're going to do with the rest of the question. But this is a very, very interesting one, and I think a lot of people will be interested in the response. Can a person have porphyria, but the DNA is negative?
So PCT we've talked about is one, certainly you can have developed the condition without having mutations. Otherwise, though, the way that we are doing genetic testing now, where we are sequencing the entire gene, including some of the non-coding regions that control the expression of the gene, it has become exceedingly rare for us to miss a disease-causing mutation. Okay, so I would say that if you did genetic testing with a reputable lab that is sequencing the entire gene and no mutations were found, I would say that it is highly unlikely that you have that something was missed. Having said that, there are some exceptions. We are discovering additional genes that are actually outside of the typical heme biosynthesis pathway that in very rare instances can cause the disease. So, but those genes are now increasingly becoming included in the porphyria gene panels. So, for example, with Invitae, it's no longer just the 8 heme biosynthesis genes. There's, I think, a 10 or 12 gene panel now. So again, I think it's a negative genetic test means that it's highly unlikely that you have the disease. Having said that, I actually will say that in general, the initial test that I always do is a biochemical test. So if I think you have acute porphyria because you're having some neurologic symptoms of some kind, I always check a urine test for ALA and PBG first. Okay, and this is especially important in the acute porphyrias because we mentioned earlier that the acute porphyrias are genetic diseases that don't always manifest in symptoms. Okay, so now this is sort of going in the other direction. If I have a positive genetic test, does that mean that I certainly have this disease and I'm going to have manifestations of it, right? The answer to that is also no. You may have a mutation in the gene that causes AIP, for example, but we've now seen that actually maybe only, if you take 100 people with that same mutation, only 1 or 2 will ever develop attacks in their lifetime. So the vast majority of people with mutations in acute porphyria genes generally actually live their entire lives and are totally asymptomatic. So it's really important for us to check the biochemistry. And if you're uncertain, even after having had a negative genetic test, where I think in general, these days I would say I'm probably 99.9% sure, okay, that you don't have a porphyria, but depending on the symptoms that you think you have, that you're experiencing, I would then just do a biochemical test, right? And that's the way to tell if the symptoms that you're experiencing are due to the porphyrias or not.
Okay. So we are going to wrap up. We've gone longer than I even said we would. But as Dr. Wang, as a porphyria expert and a clinician as well as a researcher, I would like you to share a little bit like why patients should participate in research. Why is it so critical? I want you to just share a little pitch of why it's so important, especially in rare disease, and in the porphyrias.
Yeah. So, I think I can give a pretty good perspective on this because, I also run a basic science research lab where we do some work on porphyrias. We also do some other basic biology research, just trying to understand the liver. But, a lot of times we have a lot of tools at our disposal to try to answer questions to understand the disease process. We have a lot of models. We work with cells, work with animal models and things. But in the end, all of those are approximates. Ultimately, what really matters is what our patients are experiencing and what our patients go through and how a particular therapy may actually affect our patients. Mm-hmm. So the most important kinds of research all require actually participation for patients. So that includes, that's especially true for the rare diseases. They're rare. There are few patients out there. And so we need to actually, in order to know if something works or not, or in order to better understand are patients at risk for some sort of long-term complication. We had talked about kidney disease. Today we didn't talk at all about, let's say, like risk of liver cancer in acute porphyria patients, right? Some of these observations come up, but whether or not they're really related and who is at risk, we can't answer those questions until we have a lot of patients who we can follow, who participate, and then we can follow over a long period of time before we can answer those questions. And then we talked about the process of drug approval and development that requires participation by patients. And sometimes it's difficult. You have multiple, it's a small number of patients. And then it's a smaller number of patients who are willing to participate in clinical trials. And then we are actually right now in a period of time, the last 10, 15 years has been, I think, a really exciting time for porphyria research and development of new therapies, right? So if you look before 2015, there was only one drug that's ever been approved for any of the porphyrias. That's heme. That was approved in the early 70s. And then for the next 30 some odd years, nothing. We've had no real significant progress. And then just in the last 10 years, we've had 2 drugs approved, Scenesse for EPP, gavosiran for AHP, which, that's 2 in the last 10. And then now there are currently 2 more drugs in, both are about to start probably phase 3 clinical trials soon with bitopertin and dersimelagon, again, both for EPP. So there are also early clinical trials, phase 1, I think maybe even early phase 2 study for a CEP drug, primarily in Europe. There are now early clinical trials on gene therapy for the acute porphyrias. There is a lot of very exciting, very promising research and compounds and treatment methods, options that are becoming available. So, but we can't do any of this work without participation from you guys.
Right. Terrific. Dr. Wang, we cannot thank you enough. Thank you so much for spending time on this Saturday and for answering all these questions just so brilliantly. We are so lucky to have you, as well as the other Porphyria experts of the Porphyrias Consortium. I would like to let folks know or remind people that this week is Rare Disease Day on February 29th, the rarest day of the year. It's also a leap year this year that makes it extra special. And we have lots of events going on, or we're, United Porphyrias is participating in many events. You can find information on porphyria.org. If you have further questions, people can always email info@porphyria.org. And at that site, you can sign up or join to get news and information and to participate in research. But for now, I just want to thank you and enjoy the rest of your Saturday. One more thing, the questions, we tried to get to as many questions as we could this morning, but there are many more important questions that are in the chat. So we will follow up with Dr. Wang, respond what we're able to, and we will put out the responses to the community. So with that, have an excellent day, and thank you so much, everybody. We're grateful.
All right. Bye, everyone.
Bye.